Welcome, everyone, to today's EMSC IIC webinar, Make a Difference in Your ED Through Clinical Process Improvements to Address Pediatric Suicidality. Of course, we'd like to thank our HRSA colleagues, not only for supporting the collaborative, but also for their support and their cooperation and collaboration with all of the EIIC initiatives. Thank you so much. Today, we're going to talk about the ongoing mental health crisis that you all are so very well aware of, and we're also going to talk about the launch of a critical initiative, the ED Stop Suicide Quality Improvement Collaborative. Speakers will be providing background and context on the state of pediatric mental and behavioral health, including suicidality. Also, we will clarify perspectives on the need for ED improvement efforts to optimize clinical care processes for children and adolescents presenting to the ED with acute suicidality. We will also offer options and ideas for areas of improvement. Lastly, we will describe plans for the structure of and participation in this collaborative, as well as offer details on how to register and seek continuing education credits. We'd like to ask for your help. If you have questions, most likely the structural questions about the collaborative will be answered throughout the webinar, but if you do have questions, please put them in the Q&A box. The chat is only for if you need to speak to the presenters. This webinar is being recorded. We have a very distinguished panel of speakers today. Dr. Mo Sahi-Dinajad, Dr. Susan Duffy, and Dr. Kate Remick. I'd like to turn it over to Dr. Mohsen Sahi-Dinajad now. Thank you.
Thank you so much, Laura, for that introduction. Yeah, hi, I go by Mo. I'm Mo Sahi-Dinajad. I'm a faculty at Harbor UCLA, and the rest of my credentials are here. I'm not much of a credentialed person. I'm just Mo, but and those of you who are interested, that's my credentials there. Next slide, please. So the first thing I wanted to talk about, my section is mostly going to be on setting the background and the current state of pediatric mental health in the United States. And as you all may know, mental health is one of those areas where it's a significant increasing burden on our public health system. As of now, at least 1 in 5 of every adolescent child in the age of 13 to 18 has some form of serious mental illness that they're dealing with, whether they're diagnosed formally or not. That is a number that is staggering and it's continuing to rise. One of the bigger challenges, not only the adolescents, but mental and behavioral health is starting to really increase at an alarming rate in the smaller kids, the kindergarten age and the elementary school age. And there's theories and hypotheses about why this is happening. Part of it is probably because of the technology, the vivid depiction of violence that kids get to see. And some of it also is hypervigilance in being able to notice these and think of them as mental health. What in the past used to be a kid that's just ill-behaved, but now there's a thought about let's get them evaluated for a mental health problem. There is also a problem with suicide being the second leading cause of death among children who are adolescent age group, and it's actually surpassed homicide now, and after accidents is the second leading cause. Suicidality is also disproportionately represented based on race and ethnicity. Black children are twice as likely as white children to die by suicide. Also, children who are part of the LGBTQ plus community have had a higher incidence of anxiety, depression, and other things that lead to suicidality. Next slide. And again, this is a slide depicting the differences in suicidality based on ethnic groups. also not just suicide ideation, attempts, but also death by suicide. So one of the issues here is we need to be vigilant about those who are at higher risk of dying by suicide. So we need to have some sort of a system to be able to identify which child who has suicidal ideation is likely to go on and have a suicide attempt and unfortunately have a suicide death. Suicide is lethal. A lot of children die by suicide. And the slide I have here in the lower right shows that the two most common cause of death by suicide are either suffocation and strangulation or firearms. And for this reason, it's very important to have lethal means restrictions in place. Next. So here I wanted to talk a little bit about the challenge of pediatric mental health specialty coverage in the United States. If you look at the very left slide here and graphic here, you will see the areas of the country that are either green or blue is where the psychiatric specialists, at least to some extent, are present. And as you can see, majority of the country does not have a lot of psychiatrists present. As a matter of fact, there was a article recently talked about the fact that of all of the counties in the United States, 55% of them do not have a single psychiatrist hired. That's not just pediatric psychiatrists, but there's no psychiatrist available in 55% of all counties. The two graphs on the very far right, the top one shows where the highest prevalence of mental health disorders in children are. The darker it is, the higher the prevalence. And as you can see, the one below it shows where most of the needs of children with mental health are not met. So there's definitely a discordance between where the prevalence is and where the need are. And the map in the center shows where there are shortages of psychiatric specialists. As you can see, almost the entire country is lit up with shortage. Most of the country does not have adequate access to a psychiatry specialist, and that is alarming. Next slide. So the important thing here is that the emergency department really has gotten involved because it's a de facto referral place. Since we don't have enough psychiatry specialists and there is not enough access to psychiatry specialists, the referrals are coming to the ED. These are from the families, they are from schools, they are from primary care offices, by law enforcement. And therefore, this ED is really, really acting as the safety net as it is. There's significant demand for services and there's really no supply. But emergency department wasn't really designed to handle mental health, which is why the times to evaluations are very long. The interventions that are in the ED are lacking because the emergency department isn't set for providing intervention to a boarding mental health patient. And then the next thing is the patients end up spending a long time in the ED, which takes up the rooms and also affects the ED operations altogether. Next slide. And this was an article published in the Washington Post just this week that there was a child, and this is not the only case, it's just sort of an extreme version of this. That a child who was autistic, who was basically in the hospital needing to be evaluated for escalating aggressive behavior and agitation, ended up in the ED for 76 days awaiting a psychiatric bed because upon the initial psychiatric evaluation, it was determined that he needed inpatient level of care and therefore remained on hold and had to stay in the ED. Now imagine what it's like for a child, an adolescent, to be in an emergency department in a room with likely no windows. Most of our ER rooms don't have windows and small in size probably. Imagine all the daily regular needs of feeding and entertainment and things like that. Imagine how hard that is. And that's one of many, many stories like that. Next. So there's definitely a great need for call to action. And there has been some important national steps taken in. And I wanted to, first of all, introduce you to this amazing document that we work with and have been referring to quite a bit, the Critical Crossroads. This is a comprehensive 104-page, I believe, PDF that discusses all of the different resources and care pathways for pediatric mental health, and a great section of it is dedicated to suicidality. This was published in 2019 by HRSA, and it included membership of a multidisciplinary group of individuals, from emergency medicine to social work to rural health to psychiatry. So this is a fantastic document that's available online. Last October, a joint statement from the American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association actually called this a national emergency in mental health, and published this article back in October. And earlier this year, 134 organizations were signatories to a letter to the Biden administration trying to bring attention more to the pediatric mental health issue. And since then, there's a U.S. Preventive Task Force also that recommended a screening for children who are anxious and adolescents who are depressed, because some of these suicide attempts and suicide deaths may be predicted by having early vigilance, early screening, and identification of those who are at high risk. Next. So what can we do in the ED? There is a ton we cannot do, but there are things we can do actually, first of all, before the patient comes to the ER. And those are basically being vigilant, reporting these cases early, trying to do screening, school-based screening, home-based screening, primary cares and medical homes getting more involved to avoid that from becoming an acute event that needs to be immediately referred to the ED. While in the ED, it is hard because the ED is busy, there's the volumes are high, and we wanted to be able to screen, but we want to have a way to prioritize those who have the highest need for screening, those who are at high risk. Also, we need to be aware of their daily needs. We need to understand that if we need to restrain them, we have to use the least restrictive method for doing that. And also knowing that we don't have a lot of psychiatrists available, it would be nice to have a regionalization model where a psychiatrist can be covering multiple hospitals. Space expansion when possible, workforce expansion, these are all basically more wishes than realities, and advocate for funding and support. Next slide. Just briefly, we're in the midst of getting a policy statement and technical report on the role of the emergency department in the care of children with mental health. And this is hopefully going to be published soon. I just kind of wanted to mention that this is a very comprehensive mental health that has also a great components of suicidality, talks a little bit about telehealth and regionalization of service and access to resources. Next. And the last couple of minutes, I wanted to quickly mention about what we are doing at the EMS for Children Innovation and Improvement Center. The EMS Innovation and Improvement Center is a part of the family of companies that is the EMS for Children. And it is the arm that spends a great deal of its time on developing educational content and best practice dissemination. Next. So a big component of that is the Pediatric Education and Advocacy Kit called the PEAKS. I put a QR code here. These are content that are evidence synthesized and are best practice recommendations and content that we have. They go through a vetting system through a early access program. And once they're published, it indicates that these are really highest quality content. We have been developing this through our HRSA-funded EIIC program. And again, this is just a QR code for you to take a look at them. Next slide. And this specifically is our peak content on suicide. It is organized by which of the target audiences it is intended for. It also shows what kind of format. We have a variety of formats, including webinars, interactive learning modules, bottom line recommendations and algorithms, podcasts, pocket cards and infographics. And next slide. And here is a sample of all of the content that we have for suicide. So please do go and take a look. And again, if you go back one slide again, one more time, sorry, just go back one slide. That QR code up there takes you directly to the peak suicide pages, and you can download and you can review and you can interact with any of that content. The Critical Crossroads Toolkit is actually there. You can directly link to it, as well as our bottom line recommendation. Next. And again, this was the last. So I want to now pass this on to my esteemed colleague and friend and a lifelong advocate for children's health, Dr. Sue Duffy, to take over. Thanks.
Thanks, Mo. I'm Susan Duffy. I'm a pediatric emergency medicine physician at Hasbro Children's Hospital, as part of Brown University in Providence, Rhode Island. And these are my credentials, but probably my greatest credential is that I've been in practice of pediatric emergency medicine about 27 years and have been working in the children's mental health for at least 15 of them. My job is really to talk to you about how can caring for kids with suicidality fit into, and how it does fit into emergency medicine, and talk about the rationale for joining this important QI collaborative and getting you excited about participating. You want to do the next slide? We all know that suicidal ideation and self-harm are the #1 cause of mental health related ED visits in children and young adults, and have increased steadily over the years. We are all seeing it. We can be paralyzed by that, or we can say these are our patients. This is no surprise to all of us on the front lines, as we've been in the midst of this evolving child, adolescent, and I think it's important to say young adult health crisis for years. And EDs, as Mo pointed out, EDs have become de facto sites for mental health crisis screening, and for many patients, the point of access to care. And I'm going to talk a little bit about how that evolved in our emergency department. But like for many health crises in general, EDs are the safety net for healthcare. It's where you come when you have a crisis. There are some unique challenges in caring for patients who are identified as suicidal, because at times there's covert presentations, there's a waxing and waning nature of intents, and there's a challenge of differentiating those who are at higher risk from those who need follow-up. Therefore, how do we overcome that? And I think it's by establishing methodical processes for screening, assessment, disposition planning, and having the availability of expert consultation to help us in our practice. Really, I've seen it, and I think many of you have. The mental health crisis has changed the focus and the culture of youth emergency care. I think for a long time, emergency departments rationalized that the increases would be transient, that it's seasonal, that these aren't true emergencies. So it's easier not to have to think about specific systems, that maybe it'll go away. These aren't our patients. But we don't get to choose our patients in emergency medicine. They choose us. And these are our patients. And I think there's a gradual realization. So what do? We need to adapt our systems and our culture to meet their needs. We need to change the paradigm, think about outside the box. And it involves establishing new collaborations that are really not routine to emergency medicine or routine medical care. And those partnerships are often in communities where the resources are with expertise that's not traditional from our medical referral schema that we're used to. You know, mental health problems are really chronic medical problems with acute exacerbations. And we have to become better educated as physicians, providers, nurses about the medicine of mental health problems. And so that we can understand what helps, and then where do we fit into that continuum, just like we do for other medical problems. Can I have the next slide? So why focus on ED care and a QI collaborative? It's because suicide care is really in our lane in emergency medicine. ED intervention can impact somebody's mortality and morbidity. There are 500,000 ED visits per year for youth suicide, and a significant proportion of patients who die by suicide seek care in our settings. So what we do matters. 2/3 of these kids are going to go home. So how we send them home matters. Consistent follow-up is variable, and specific referrals are really less than 50%, although I think we're going to see that improve with more resources. But there's an increased risk of mortality within a year of those who seek care for self-injury and for increased suicidal ideation. And the peak risk period is in about 3 months. So really, ED interventions can impact mortality for these patients. So how should we focus our thought processes in the emergency department? I think it's to do it just the same way we do how we use our strengths of emergency medicine and ED assessment and apply it to this paradigm. What are we good at? We're good at screening on differentiated patients. Suicide is not always obvious, and therefore we have to build mechanisms for universal screening. We're good at identifying potentially life-threatening conditions. That's where suicide assessment with a positive screen is important so that we can say which determine the level of intervention that's needed in the emergency department. Some patients may be able to send home with follow-up. Some patients need a higher level of care. Some patients need intervention right and now. We're good at creating, monitoring, and assessing our patients, observing them, figuring out what level of service you need. We need to build those same systems in our emergency department to keep our medical environments and our patients safe in the emergency department as well as our staff. We're good at figuring out how to do focused assessments. What are the acute medical issues? What diagnostic evaluations are essential? What consultations do we need? Who can we talk to by phone? Who needs to come in and see a patient? We need to set up the same processes for consultation for children with suicidality. And then, just like we do for everyone else, we have to establish safe and appropriate disposition and plans for ongoing management and care, handing off patients, making transition to care, make sure there's shared decision-making with families. Those are all things that come naturally to us, and it's just how do we adapt them for this patient population. Next slide. Let me tell you a little bit about my emergency department, or our emergency department. Hasbro Children's Hospital is a tertiary care medical center in Providence, Rhode Island. We are it for our catchment area. Rhode Island's the littlest state. We've got one children's hospital. We're an urban emergency department. Right now we have 50 beds. We see 60,000 patients a year. 3,000 of those patients have mental health complaints. We are lucky enough to be affiliated with the Children's Psychiatric Hospital, not on the same campus, but close by. So it's a good resource. This is a picture of some of our rooms, 20 of our rooms from our EPIC track board from the other day while I was writing the slide. 12 of these patients have mental health complaints. And there were 4 more in other beds. There were 8 waiting to be seen. There were 40 patients in our waiting area. Our emergency, we're boarding medical patients. We're overwhelmed with RSV bronchiolitis. This is overwhelming in a sense of so many kids. As I said, our former short stay unit is full. We turned it into a psych boarding unit. So this is a overwhelming process in a way, but we have a handle on it. We don't have enough resources. Kids wait for days because there's nowhere to go. We have to gather all of our resources, but this was a process. We have systems in place, but it occurred over a year. If I look back from 12 years ago, we had no psych consultation in our emergency department. We had social workers who would evaluate the occasional patient who came in. Many children had medical conditions that were related to suicidality, so were admitted to the hospital. We transferred patients to the child psychiatry hospital who needed a higher level of care. We discharged a lot of kids by car who didn't even have an evaluation to go somewhere else to be evaluated. It wasn't until we had some bad outcomes that we recognized that we couldn't do that anymore. And we started to look at what can we do. So we gathered our resources together and started a daytime psych consult service. We had none at night. People waited overnight in our emergency department until someone showed up to do their evaluation the next day. And at the simultaneously, the perfect storm, and this happened, I think, everywhere in the country, federal funding was cut. So community mental health centers curtailed their emergency services. There were fewer places to go, and our volume increased. We became the point of access, especially for the most vulnerable patients, those with special needs. Schools increasingly started to send us kids that they couldn't manage. So we eventually, about 8 years ago, established an emergency child psychiatry service. We hired a child psychiatrist who specialized in emergency care. And we had a team of social workers and licensed mental health providers, and we have never had enough resources. Even in a well-resourced place, it became a teaching service, but it's always been consult-based. The patients are under the care of the emergency department. The patients are integrated within our ED population. We have some dedicated rooms for safe rooms. And the things that we had to deal with bit by bit with very little guidance was how we had to train all of our staff in de-escalation. We had to initially admit at our borders to inpatient service, but there were so many and they became overwhelmed that more and more kids were boarding, and particularly those who were at risk for escalation. We adapted our environment. We developed diversions and distractions, and we adapted our rooms to accommodate these patients. We found a need for pathways and started to collaborate with others looking around the country of who else is doing stuff. We opened a crisis clinic within the past couple of years, and that crisis clinic is now overwhelmed, so can't really meet the wait for a crisis clinic appointment is about 3 weeks. These processes we developed out of need, as I talked to colleagues around the country, many others have done. And so there hasn't been, this is really a chance to start to share those best practices with each other, and then realize that everything is local. You have to adapt them to your resources. And the next slide. So over the 10 years or so, there have been movements to develop systems to respond to suicidality. And zero suicide is really was the first roadmap for suicide care. Zero suicide really focused on adults, but it did something that was really powerful. They looked at ED care as part of a continuum of care and the recognition of the importance of community collaboration and patient engagement to improve outcomes. Once again, outside our paradigm, and really powerful because highlighted evidence-based practices and also established quality indicators for best practice care, but really wasn't focused on kids. Next slide. And that's where Critical Crossroads came in. This group of multidisciplinary, very rich group developed a toolkit for pediatric mental health care and really focused on preparedness and readiness of emergency departments to care for children with mental health problems. And that includes suicidality, and really outlined quality processes, best practices, a framework and an approach for following patients from arrival to disposition, and really acknowledging the importance of pre-hospital care, which I think we're having increasing recognition and even possibilities of diversion, and also the importance of follow-up. Next slide. And then, as Mo mentioned, the American Academy of Pediatrics, particularly in the past few years, has really stepped up. We partnered with the American Association of Child and Adolescent Psychiatry and the Children's Hospital Association to declare a national emergency in youth mental health to really bring attention to the issue, but also convened a youth mental health summit. And a document that came out of a result of that is a really powerful tool that I really love. And it's called the Suicide Blueprint for Youth Suicide Prevention. This blueprint is full of useful tools and referrals and processes that can be integrated into ED care and also primary care. And it really helps bridge those two and the really integration of what we do in the ED and how that fits back into primary care. Next slide. So why be part of this QI collaborative? Because we can have an opportunity to develop ED suicide quality measures and the basics, like the fundamental processes that every ED should establish that are age and developmentally specific and family focused. It's really, that's the important part of this collaborative. And I think the issues that we will work together in the collaborative will be around suicide screening. For example, the Ask Suicide, as there's up above, safety assessment, such as the Columbia assessment, ED medical screening and focused exams. What's important? What are the important conditions to meet and how can we identify them? When do we need mental health consultation and what level and how can we focus that? Are there room for ED brief interventions in some emergency departments, but not all? How do we develop safety plans for every single patient who's discharged, who's at risk for suicide? And that includes lethal means restriction counseling. You know, the evidence has really shown if we do the most important thing perhaps we can do in emergency departments is develop safety plans and do lethal means restriction counseling to improve outcomes. And then the importance of ED follow-up and transitions of care and how do we collaborate with the community? Those are all important things that we can do in this collaborative. Next slide. So, and then work together to think about who's got best practices for adapting your EDs and care to meet the needs of youth with mental health crises. You know, everybody works in an emergency department did it because we are crisis junkies. We are used to chaos, bringing it together. But as these pictures display, that is not the mentality of how to best care for children with mental health crises. And so we can't all design psychiatric emergency departments and don't have those resources, but there are things that we can do, then share those practices. Next slide. So finally, you know, think about how to make best practices in a QI collaborative and make sure that everything is local and define what works for each of our EDs. And that will require all participants to do an assessment of your ED for preparedness and cares for children at risk for suicide, to look at, identify your internal, external resources. I think if I've learned anything over the years is the collaborators are in places you never would expect. And the champions come from all over. And the importance of champions, and then building your team, and then finally evaluating the processes and changing and tweaking so that we can sustain this. So next, I'm going to turn it over to Kate Remick, who runs this collaborative and is really going to explain more about the workings of the collaborative.
Thanks so much, Sue. It's really nice to be with you all today, and thanks so much for joining. We certainly couldn't offer these collaboratives without our subject matter experts like Dr. Sadinajad and Dr. Duffy, who joined us today. So thanks so much for that wonderful overview. And I think they really provided the why behind this quality improvement collaborative. I am a pediatric emergency medicine and EMS physician. I'm based out of Austin, Texas at the University of Texas Dell Med School. and I serve as co-director of the MSc Innovation and Improvement Center. So we'll go to the next slide, please. What I'd like to spend the next 15 minutes talking about is, now that we know the why behind this, the question is, how will we do this? And what do we hope to accomplish? So this is the ED Screening and Treatment Options for Pediatric Suicide Quality Improvement Collaborative. And we'll just jump into some of the details of that. Next slide, please. I wanted to share a little bit before we jump into these details about the EMS for Children program. And I know Dr. Suicidality spoke to this a little bit, but the EMS for Children program is really the only federal program designed to focus on pediatric emergency care needs within our emergency care systems. The work that we do is really centered around reducing death and disability secondary to both illness and injury. And we focus on this across the entire continuum of care, from pre-hospital care to hospital-based care to transfers and back to the medical home. I know there were a few questions raised in the Q&A about EMS systems, and we can certainly address those during the Q&A after we finish up today. But the EMS for Children program funds a number of programs across the United States and every U.S. state and territory through our state partnerships, funds the Pediatric Emergency Care Applied Research Network, which develops much of the evidence for the work that we do in pediatric emergency care, as well as a data center and the MSc Innovation and Improvement Center. So why is such a program like this needed? And if we'll go to the next slide, please. What we know is that when it comes to emergency care in the United States, pre-COVID, there were about 35 million pediatric visits to emergency departments. I think given the recent surge, we're on track to closer to 40 million. But the great majority of these visits happen in general emergency departments, whether that be a community ED in an urban setting or a rural ED or a critical access hospital. And the crux of this is that the majority of patients in these emergency departments are adults. Children make up only about 20 to 25% of it. And therefore, when we look at actual numbers, about 70% of all emergency departments see fewer than 15 children per day. But yet that's where the great majority of children are seen. And so one of the questions becomes, how do we maintain our everyday readiness to care for these children? And there is a joint policy statement called Pediatric Readiness in Emergency Departments. For those of you who are here with more of a pre-hospital or EMS lens, there is a similar joint policy statement that provides recommendations on how we can better ensure readiness to care for children in our EMS systems as well. But these guidelines really help us to understand who needs to be present, how do we do this work, why is it so important? And one of the components is really around policies, procedures, and protocols, and really helping us to identify what are common conditions that children present to the emergency department with, and how do we work towards standardizing that care so that we are providing the highest quality care according to evidence-based guidelines, which we know then results in improved outcomes for these children. If you go to the next slide, please. I wanted to spend just a few minutes talking about what we do within the EMS for Children Innovation and Improvement Center, also known as the EIIC. And our work is really to take much of the evidence-based guidelines that exist and try to figure out how we can increase access to high quality emergency care across that entire continuum. We do this with the support of national partners, partners of national professional organizations, partners with families, partnerships with other federal entities, including Indian Health Services and Federal Office of Rural Health. We also work really hard to try to identify what are the evidence-based guidelines, as you heard earlier today about the Peak Suicide Kit and the Critical Crossroads document and the blueprint for suicide, and really figuring out how can we identify what the evidence-based content is and modify that into more tangible resources that can be easily accessed and provide educational modules and the like related to those. And that's really what we call knowledge management. And the last really area of focus within the work that we do is to try to leverage quality improvement science. And we do this because we know that quality improvement science helps us to drive evidence into practice by creating an opportunity to really reflect on the current evidence, identifying where our opportunities might exist and making changes to result in improvements in patient care outcomes. If you go to the next slide, please. All of our quality improvement collaboratives that we lead are based on the Institute for Healthcare's Improvement Breakthrough Series model. And this really stems from the model for healthcare improvement, which is really What are we trying to accomplish? In this case, we're trying to improve outcomes for patients who present to the emergency department with suicidality. And the next questions are, how will we know that any change we make is an improvement? And what change can we make that we know will result in an improvement? So how are we measuring the work that we do, and what changes are we making? And we really take this model and spread it into a national quality improvement collaborative that provides an opportunity for us to learn from each other. What changes have you made in your emergency department that have worked for you? And how might I adopt that in my emergency department? And it allows for a real sharing of best practices over time. We spend a lot of time in the few months leading up to these quality improvement collaboratives, developing the framework and the content, really making it much more accessible to a larger audience, of really translating that evidence into practice. And then over a period of typically 6 to 18 months, we walk through a series of change cycles, which are often referred to as plan, do, study, act cycles, or PDSA cycles, to really support individuals who are interested in this work. If you go to the next slide, please. The other benefit of our quality improvement collaboratives, in addition to really beginning to partner across institutions and across the country, is that we create a lot of centralized resources. We really whittle down that evidence-informed content to create really important key areas of focus. Like I said, we use that QI methodology. We offer project management support and all kinds of infrastructure to make this quality improvement work simpler. And people do not need to be quality improvement experts by any means to engage in a quality improvement collaborative. And in fact, most of our collaboratives are directed to individuals who are really passionate about improving care, but may or may not have any hands-on experience in leading large-scale quality improvement efforts. And so we really take the time to help support any of our participants in doing this work. Next slide, please. So the ED Stop Suicide QI Collaborative is really focused on enhancing our ED-based clinical care processes for children with suicide ideation. You might be asking, why not pre-hospital if you're covering the entire continuum of care? And part of the core components of a QI collaborative is that it's really derived from evidence-based content. And as many of you may be aware, in the pre-hospital setting, much of the evidence around how we manage children with mental health emergencies is still evolving. There may, however, be opportunities for engagement with core ED-based teams and how we can really partner together with our pre-hospital colleagues. But the core of this is really focused on enhancing our ED-based clinical care processes. Within this collaborative, we have amazing subject matter experts in pediatric mental health and suicide. We have QI experts, lots of opportunities for networking, ways to really think about driving that evidence into practice within your facility, within your region. We'll provide you with resources and tools, shared opportunities for learning. We'll talk a little bit more about that. And then most importantly, an environmental scan so you can really reflect on the current state of care in your emergency department and try to identify areas of focus for improvements. All of our quality improvement collaboratives offer continuing education credits and MOC Part 4 credits for those of you who are physicians. And this is, of course, at no cost as we are 100% federally funded, thanks to HRSA. Next slide, please. Dr. Duffy mentioned some of the key steps of the clinical care process in addressing children who present with suicidal ideation. And these are some of those that we really hope to focus on during the ED Stop Suicide Quality Improvement Collaborative. So if we were to put these into buckets, screening and triage, mental health assessment, ED-based interventions, which also includes patient and family considerations. And you heard about the case of the autistic boy who spent an innumerable number of days in the emergency department boarding. We'll also talk a lot about disposition and safety planning and really beginning to learn how we can leverage regional resources to expedite and optimize disposition for these children. Next slide, please. We're asking that everyone who registers for the ED Stop Suicide Collaborative really tries to work within a team. It's really hard to initiate and successfully implement quality improvement projects if you are just a team of one. We realize many of our participants may come from critical access hospitals or rural areas where there may not be a large group of staff to choose from. But we know that when it comes to mental health care, this is truly a multidisciplinary effort. It involves, yes, nurses and physicians, but it also involves social workers, child life specialists, technicians, security, sitters, sometimes C-suite or ED leadership. Families are a great option to bring into the team, and or other mental health professionals, both within and outside of the hospital or inpatient setting. We estimate that this work will take approximately 2 to 6 hours per month, depending on how much time and effort your team is ready to dedicate to this. But our goals are really to work together to enhance this process by first identifying within your emergency department what are the critical needs or gaps within our suicide care process for children. How can we seek organizational buy-in from our leadership? Begin to really think about whether we have all the right people on our team, implement those changes, and then assess the impact of those efforts. Next slide, please. This is really just a simplified version of the collaborative structure and what that looks like. Many of us on the call today are part of the core support staff within the EMSC Innovation Improvement Center. We're working very closely with subject matter experts like Dr. Duffy and Dr. Sidinajad, as well as quality improvement experts across the space. What we hope is that each emergency department-based team will identify an area of focus, whether that be screening and triage, assessment, ED interventions, including family considerations, and ultimately disposition and or safety planning. It may be that within your emergency department, you can accomplish more than one of these areas of focus and really make some significant strides to improvement. But our hope is that each emergency department-based team can at least choose one of these areas for focus. And as we move into the latter phases of the collaborative, we'll begin to really look at how we can leverage regional resources to support this work. Next slide, please. So when we're talking about regional resources, there are a number to really highlight. First off, what we hope to do is create opportunities for partnership with others who are participating in your state or region. We also will provide opportunities for you to connect with the EMS for Children State Partnership Program Manager. As I mentioned, every state and U.S. territory has an EMS for Children State Partnership Program Manager whose work is really dedicated to ensuring high quality emergency care for all children in that state. And they are heavily invested in this work and this effort and are a wonderful resource to be able to support you and provide other opportunities. Also really working to leverage pediatric mental health care access grantee programs. There are currently 50 of these across the United States, 2 that are in tribal areas, a few in U.S. territories as well. And these programs are designing essentially telehealth support systems for children presenting with mental health emergencies. These were designed predominantly for outpatient clinics and primary care physician offices, but many are interested in looking at how they can begin to support emergency care systems as well. And then lastly, beginning to look at how we might be able to better collaborate with school districts, primary care physicians, and of course, EMS systems and other regional stakeholders within the emergency care space. Next slide, please. So our SMART aim is that by the end of this collaborative, which is November 2023, and we'll talk a little bit about SMART aims in this collaborative, but our hope is that 100% of our teams will have identified and implemented at least one strategy to improve their clinical care processes for children with suicidal ideation. This collaborative will begin on Thursday, February 2nd with our initial kickoff and orientation. We'll start by looking at an environmental scan to identify opportunities, some QI planning. There'll be lots of opportunities to learn from national subject matter experts during our fireside chats. And then we'll begin to mobilize teams to identifying that area of focus, choosing a change strategy, SMART aim, and really beginning to accelerate those improvement efforts over the spring and summer. During those months, during our learning sessions, this will be an opportunity for all of our participants to share with each other what they've done, what kind of successes they've had, what barriers they've had to work to overcome, and really hear from others about ideas and other strategies that they might try to use. And then lastly, as we move into the fall, we'll really focus on establishing partnerships for sustainability and really diving into how we can better leverage those regional resources. Next slide, please. This is a brief calendar of events. So this is these are monthly learning sessions. These will be held on the first Thursday of the month. And the goal during those first ones will be to really orient all of the participating teams to the collaborative structure and approach. Again, there'll be coaching and guidance for QI planning, sharing of best practices. All of these will be recorded. So for those of you who aren't able to attend every single session, there will be an opportunity to go onto the EIIC website and listen to these recorded sessions as you begin to work through some of these changes. The fireside chats noted in red will be sprinkled throughout those first couple of months of this collaborative, where you can really learn more about the evidence and best practices and have an opportunity for Q&A with those individuals. The summer months we know are always challenging with vacations and schedules, but we do plan to host some regular office hours in addition to one-on-one coaching as needed to support folks during those summer months as you work towards your improvement projects and efforts. Next slide, please. As part of this quality improvement collaborative, we've created a number of centralized resources to support you. You've seen the suicide peak kit, but in addition to that, there are intervention guides for each of these focus areas, a QI planning guide. We'll share with you the peak suicide kit and critical crossroads. We've developed an environmental scan to help guide you in trying to understand what are the strengths and weaknesses related to workforce, resources, technology, and culture. Access to these subject matter experts and shared best practices. We have centralized project management support to help you, and also data and analytics support to help you share back to your hospital and ED leadership all the great work that you are doing related to pediatric suicidality. Next slide, please. During our sessions, as we move into implementing changes, we will ask all of our participants to really be active participants. And we usually will share a 2 to 5 slide template for you to introduce your team members, talk through what you're trying to accomplish or what you've identified, what successes you've had. We'll have opportunities for small group breakout sessions where you can really share with each other and hear from each other. And as I said, this is really an opportunity for shared learning. So within our quality improvement collaboratives, we know that everyone has variable resources, variable challenges that they're addressing, and really we're here to support all of you. It's all teach, all learn. It's asking questions. Any improvement is success, and we want to celebrate those and really support one another. So there's no specific level of achievement that we expect every team to get to, but it's really about celebrating effort and remaining engaged in this process. Next slide, please. So this is just the last piece. Again, we will be offering continuing education credits, physicians, nurses, social workers. For those of you who are physicians that choose to engage in this work, if you are seeking MOC Part 4 credit, you are required to complete a quality improvement project. We have templates to help support you in submitting that. It's a pretty simple process, but a great way to get your MOC Part 4 credit. So thanks so much. Thanks to Dr. Duffy and Dr. Suicidality, and I'm going to turn it back to Laura Eyre to wrap us up. Thank you.
Thank you, Dr. Remick. And I apologize, I should have introduced myself. Laura Eyre with the EIIC. I'm a senior project manager and I oversee the quality improvement collaboratives as part of a larger team. So our registration will open this week. We're hoping for sooner rather than later. And I did put the webpage where this information will be posted at the top of the page into the chat feature. And that's where we'll also share the recording and the slides, but we will also be emailing to each of you as well to let you know when things are ready to move on. So I think that Dr. Remick already explained most of the information about the collaborative, but we will ask the ED team leaders, so one person among the team designated as a point of contact, to complete the registration online. It takes less time to register than it does to actually talk about it. If you have 2 or 3 participants from your ED site on your team, we'll just ask for their names and email addresses. And if you're collaborating with up to 2 additional neighboring ED sites, we just ask that you name which sites those are, and then the team leads from those sites will also register. If you're part of a larger team, maybe a healthcare system or an emergency care collaborative, then just send an email. My email's in the chat as well, and ask for an exception to see if you can have more than a few neighboring ED sites to be part of your team. The environmental scan is a document that the team leaders will also be asked to complete. It just basically asks what clinical processes you already have in place. And that way we'll know where the group is. And then hopefully as you complete this environmental scan before and then after you participate in the collaborative, we'll see improvements. We will ask you to complete registration as soon as is feasible after we open, only because we want to get those environmental scanned documents out to you as soon as possible. Most of the questions have been answered either in the chat or the Q&A box, but if you want to reflect on what the panelists have said and pose additional questions, please put them in the Q&A chat now, and we'll pause for a moment to let you do that.
And Laura, this is Mo. Just to reiterate the question about the international ED teams that would like to participate.
I'm sorry, Mo, say that again, please.
There was a question, I just want to make sure it was addressed, about international ED participants.
Yes, they are welcome. Internet willing, you are welcome to join. And if you need additional one-on-one consultation, whether you are from within the US or the territories or in international areas, just reach out and we'll help you individually as well. I'm looking in the chat. And the question is, will we also track compliance with improvement efforts in addition to expected actualized outcomes? Kate, what are you thinking?
So I'm not sure I fully understand the question about compliance with improvement efforts. If you mean whether staff are following that, we would defer to you. It's not for us to say exactly what you change or how you change it or how you want to track that, but we will be tracking, at least at this juncture, what kind of changes are being made and what kind of work is being done. There will be an opportunity at the end of this collaborative or as we move into late spring to join a subsequent collaborative that will allow for more granular evaluation of how this work is impacting actual patients. But in terms of whether or not staff specifically are remaining compliant with the efforts, we probably won't have the ability to do that centrally and would defer to you and your site at whether you wanted to do that.
Thank you. There's also a question about continuing education credits for paramedics. I'm not sure of the answer.
So in the past, we have offered CAPC credits for EMS professionals, and we are anxious to see who all is registering for this particular collaborative so we know whether that would be of value. Because this is predominantly an ED-based quality improvement collaborative, we weren't certain as to the extent of participants who would be EMS professionals. But if there are a significant number who are working in emergency departments as technicians or support staff, we'd absolutely be in support of creating CAPC opportunities for you. So more to come specifically on CAPC credits, but can certainly share that we will be offering C&E credits and continuing medical education credits for physicians as well as for social workers.
Thank you.
Just to clarify, I think the question was related, do they get the credit for the webinars?
Yeah, and for each credential level, it's a different type of credits, but we will be offering credits with participation in each of the webinars.
Well, we're at the top of the hour. There are a few more questions. However, we'd like to point out some critical resources. And we'd also like to thank you for joining us today. So we hope that everybody has a good day. And if you have further questions, or if we didn't comprehensively address your question, or if you want to discuss further or figure out how to get involved, please do send a message. Thank you so much. Thank you so much to our panelists today too. We appreciate you taking the time out of your busy schedules, and to all the participants as well. Have a good day.